Hi, everyone, and welcome to our webinar. My name is Ken Bell. I'm the Vice President of Marketing for Simple LTC and Briggs Healthcare. Thank you so much for joining us for our training today, which is entitled Taking GG from Good to Great, Capturing True Baseline and DC Status. So as you may recall, this webinar was originally scheduled for mid-March, about 5 weeks ago, and then something happened, and we're in a whole new world now. And so as the whole world has been facing this COVID crisis, we know that in particular in post-acute care and skilled nursing, everyone has been especially hard hit. And we want you to know that we think all of you are doing a heroic job managing the crisis in your facilities. We applaud that, we salute that, and we want you to know we're behind you every step of the way. And so many of our customers at Simple LTC have told us that despite the daily challenges they're facing right now, they're doing their best also at the same time not to lose focus on MDS accuracy and training and things like that. So we felt it was important to move ahead with this training because even if people can't necessarily attend live, they'll also have access to the recording and the handouts and the resources and the other things from this training available as they need them. So we are moving forward to the training today. We're so glad you're here with us. And our topic today is Section GG, which we all know is a significant driver for reimbursement, but it's an area that's often overlooked, especially when it comes to documenting key factors like baseline, discharge, and goal data. So we're very excited to partner today with Quality Rehab Management, QRM, for the webinar. And as we get into our content, they'll present some common Section GG challenges, as well as several real-world examples that will help you understand the effect GG has on your quality outcomes and your reimbursement. So before we get started, just a couple of quick housekeeping items. For questions and answers, we're expecting probably several of those today. You can type a question at any time into the Q&A box on your webinar panel. Feel free to do that at any time during the presentation. Melina with Simple LTC is with us. She'll be monitoring those questions as they come in, and then we'll cover as many of those as possible in our Q&A section at the end. And then one thing to note, we've turned on the capability to upvote questions. So if you see one that you think is particularly relevant or you want to make sure that our speakers see, you can go ahead and upvote that. Be sure to do that, and then they'll be sure to see that question at the end. And then handouts, people always ask about handouts. If you don't already have them, we'll post a link in the chat. Melina will put that on there, and you can download the file in PDF format, so you'll have the handouts and slides there with you as well. Now I'd like to go ahead and introduce our speakers. First is Susan Kroll. She's the Chief Strategy Officer with QRM. She has over 30 years experience in multi-state post-acute rehab management, and her client base includes privately owned and national for-profit and also non-for-profit skilled nursing facilities and CCRC campuses all across the U.S. And at QRM, Susan works with clients to create strategies that improve outcomes and patient satisfaction in today's value-driven and person-centered environment. Also from QRM with us today is Megan Ussery. She is their clinical reimbursement specialist. She's RAC certified with more than 12 years experience in long-term care and a career that has spanned several different roles, including unit manager, MDS coordinator, and clinical reimbursement. She's very passionate about care planning, addressing resident needs, and partnering with the IDT teams to optimize clinical outcomes and reimbursement. And finally, also with us is Corey Pauley. He's the Director of Product and Software Engineering at Simple LTC, where he oversees our product roadmap and software development. And he's also the primary designer and architect of Simple Analyzer. So with that, we're going to go ahead and move into our presentation today. So Susan, I'm going to turn it over to you to walk us through the agenda.
Perfect. Thank you so much, Ken. To everyone listening in, we do want to express our most sincere appreciation for the heroic work you're doing out there to provide the safest and best possible care to our vulnerable population. We did opt to move forward with this GG presentation in the midst of all this, and we will try to be as concise and respectful of your time as possible. Prior to COVID, we were getting settled into our world under PDPM reimbursement. And as we began to look deeper into the data for trends and opportunities and the story that we're presenting to CMS about our outcomes, we felt compelled to revisit GG. We're going to share some GG data with you today and discuss how we can make certain we are gathering the most accurate information, not only to improve our patient care, but for reimbursement today and into the future. So taking a look at the agenda, we'll be talking about why we feel GG is so critical And first of all, we'll take a look at the full impact of GG, self-care, and mobility scores in today's world. How are they used, right? So they're used for PDPM reimbursement, as we know, for the PT, OT, and nursing components. The QRPs, the items that are being pulled here, tell our outcome story to CMS. And then this is helping to set the stage for our future in a post-acute uniform payment model world. We're going to dig into that, and we're also going to be talking about and looking at what it is our industry is reporting to CMS through some of the data available. We're going to be talking about gathering true baseline and discharge GG levels, which we really, I don't think, have spent enough time talking about, since that is really what is telling the full picture. It's not only the baseline, but the outcome, right? The discharge GG level. Then we're going to talk about strategies. How can we really make sure we're getting the true baseline accurate picture of usual performance and discharge performance? And then monitoring for optimal success, clinically and financially, and looking at some of the tools that are available to us right now. So the next slide, we're going to go into a poll. Thanks, Ken.
Okay, we're going to go ahead and launch. We've got a couple of live interactive polls, and this will be the first one. And the question is, how are you gathering your GT scores now? So go ahead and click on your screen. Please vote now. This is live, and we'll share the results here in just a few seconds. But Susan, is there anything specific you'd like to say about this poll?
Well, we asked the question because historically, I don't want to lead the answers on any form or fashion, but historically, I believe since 2016, conveniently, GG items are very much what we address in physical and occupational therapy, of course. And so it's part of our evaluation. We ask the questions prior level, we ask we get a baseline, we set goals, and we complete a discharge summary. So it was natural for us to help provide GG information. It was never intended for therapy to present the true usual performance to be input on the MDS. However, the industry tended to shift that way. So we're going to talk a lot about that today. So I'm very curious how people are today gathering their GG scores.
Okay, well, thanks to everyone for voting. Looks like we have well over 60% of our audience who's done so. I'm going to go ahead and end this, and then we'll share those results.
As I thought, therapy only.
Mm-hmm.
Yeah. And okay. Like 79% all the above. I should not overlook that. That was huge. 79% said all the above, and I'm very thrilled to hear that. That's huge. That's the intent, right? That it's an interdisciplinary approach. So what does GG impact, right? Let's really look at this. So the impact, speaking of impact, the Impact Act of 2014 mandated a massive movement towards that uniformity in gathering data from all these post-acute care providers. So they started, implementing the same set of questions that we see in GG across LTACs, inpatient rehab hospitals, home health, and SNFs. And what they're trying to do is work towards a unified post-acute payment model. And they set a date of 2024, which seems closer and closer every day, right? GG, they're looking at all of us, right? They're comparing all of the post-acute settings to see what patients we're getting in, what is their baseline, and then how are we using that baseline to guide our delivery of care, our care planning, and the transition readiness. So GG information that we get really does help us do all of those things, right? It guides us in our goaling and our care planning and our transition readiness. The QRPs, which are also taken from GG, began as a penalty of 2% of your reimbursement if you had too many dashes, which meant your assessment was not complete. A dash means you did not assess an item. So it was really forcing us to be complete in our assessment of the patients. And then we wanted to really capture the functional improvement. So our QRPs, as of today, January of this year through December of 2020, right now is determining our 2022 QRP picture. CMS is right now looking at what we're telling them to assess the functional outcomes that we are achieving in PDPM. And when PDPM rolled out, it was very clear. Now that we're not driven by days and minutes of therapy anymore, they're watching closely. Are we decreasing our days and minutes of therapy? How much are we decreasing it? And what is that doing to impact our outcomes? And if we let our outcomes slip, there will be a penalty of some sort. We don't know what, but they were very clear that would not be acceptable. So the QRPs, the information we're putting in GG right now, is impacting our story that we're telling on our outcomes, which does impact our future of reimbursement under PDPM, and that 2% that we will get taken away if we are incomplete in our assessment. And that includes our goal setting. We need to have at least one goal, and we'll talk more about that later. And we are showing them our improvement in our discharge GG goals. Then the other thing is that it impacts our PDPM reimbursement for PT, OT, and nursing in a very big way. So they are reimbursement drivers, and we know how critical CMS looks at information provided that drives reimbursement. So this will be looked at. We know it will. And we do know, again, that the future of the SNF payment model in our space is largely going to be judged and determined based on what we're telling them in our GG data. How are we doing at a SNF level in taking our patients to a successful discharge? Lower return to acute, better, safer community discharges. What is our episodic cost of care? This all goes into the bigger picture to determine our future. Okay, and as we move forward from there, everything is driven from the MDS, right? All of this, 161 items drive PDPM, I believe was the last number I heard. But I wanted to share with you the MDS, that is the driver. This is where GG is recorded. And so I just wanted to point out a couple of things. This is a Briggs tool. It is a color-coded MDS, which is quite handy. And if you look closely, you will see a green outlined box with a little bag of money, a $sign in it. Whereas anything that impacts PDPM reimbursement has a little money bag. Anything that impacts the QRPs has this little hexagon symbol. So as we're looking at this section, this is something I think that is not necessarily discussed or paid enough attention to as well. These are the prior functioning, this is the level of prior functioning that we are gathering and telling Medicare, okay, here's where the patient was before in their self-care, their ambulation, their stairs, their cognition. You know, they used a walker or none of the above. We're telling Medicare this is their prior level of function. This information is going to be used in setting up the expectation for this patient's discharge status. This matters. This is going to be part of the equation when we look later on in our presentation at the QRPs. And what is the story we're telling? What is the expected outcome? So then as you go scrolling through a little bit to the next section on the MDS, you're going to see how it lays out section GG. You see the PDP GG items are outlined in green with that little green money bag there. And you see the hexagon, which is a representation of all of the items that are going to impact your QRP. So this is your outcome information. So when the CMS is saying, we're going to look at your outcomes, I was like, well, what outcomes are they going to be looking at? This is it. Anything with that little hexagon, they're going to be looking at it because that's going to impact the outcomes. So let's go back to the presentation then and look at the next slide, which is going to go into another GG poll. So Ken, I'll turn it back to you.
Okay, I'm going to pull up a real quick second poll that has to do with GG admission scores. So based on your patient trends, do you feel your GG admission scores on average are, and then there's several things to choose from, 100% accurate, too high, too low, or you honestly don't know. So I would imagine we'd have some interesting mix of results here. Susan, anything specific you want to point them out to?
I think that we absolutely want to make sure that we're capturing true baseline. So when we're thinking of baseline versus discharge, if we don't capture the true baseline and the true amount of help that that patient needs in those first 3 days, we're not going to be able to show the progress that we truly are making, nor are we going to get the reimbursement that we are due for caring for that heavier level of care patient. So I want to make sure it's truly, truly accurate. So I'm curious what people are saying that they believe and before we look at the data.
Okay, we'll leave this open for maybe 10 more seconds, give a few more people a chance to vote, and then we'll share those results for you.
Great, thank you.
Okay, thanks everyone for voting. Looks like we've got well over half of our audience who voted. I'm going to end that now and share those results.
Too high, based on, yep. Do you feel your admission scores on average are too high? We seem to rely on the therapy assessment of GG due to lack of supporting nursing documentation. That is the crux of the matter. That is why we wanted to do this webinar, because we all are struggling in this industry to figure out how do we do this. This is so hard. We used to have a kiosk that the CNAs would input what they were doing. How do we find out what's happening at bedside, get it into the medical record, get it into the hands of the IDT team to assess what is the usual performance? So that's what we're going to try to talk about again as we go forward. So the next slide, we're going to show you a tool that we have that is a scoring worksheet. This whole process is not easy. So first, what you have to do on the MDS, well, first you have to get the information, right? Well, we'll talk about that in a second. When we look at this spreadsheet, we wanted to help out a little bit because these are the PDPM GG items on the left-hand side. So you'll see the first item is self-care or eating, and then that will have to be coded. So you click on that GG response code. So you click on that, there's a drop-down arrow, you click on the arrow, and then you decide. This is to be used at the time, it was designed to be used at the time of the interdisciplinary collaborative discussion to determine what is usual. If you decide that, you can see right now it says partial moderate assistance, which is a score of a 2, and I'll show you that in a second. But if you click on now substantial max assist, or whatever one you want, it changes the score. And then over to the right, you'll see the PT and OT is scored and nursing is scored because you have to have a, your PT and OT will have a different score than nursing because there are 2 things that are not included in the nursing score that are included in the PT and OT, and I'll talk to those in just a second. But this is to help you get through this because you have to, if you don't have something like this, then you're left to having to do this manually. And when you get down to mobility, sit to lie, lie to sit on the side of the bed, that's basically your bed mobility. You have to code each one, score each one, and then average those to get your mobility lying score. So instead of having to go through the rigmaroles of all the math and all that jazz, this is a helpful tool to help save you some time. We have heard good feedback, use it. It's going to be available to you. It's a tool to use if it will help you. It has helped us. So as we move, there's the button that you'll choose. Okay, so as we talk more about this whole coding scoring situation, I don't know why it has to be this way, but here's the deal. On the left is your code, right? That would be coded in the MDS. You code the MDS. But for PDPM, there is a score. And I just want to make sure that for the PDPM impact of GG, we're really understanding what we're looking at when we see the score. So when in the MDS, let's say someone is independent, under GG it is 6. 6 is independent, substantial max assist is 2, and then 0, 1, you've got dependent, and you've got refused, not applicable, and not attempted are other coding options that you will have. Each of the codes will then behind the scenes be scored. So as a team, we want to know what it is that we're, what are we telling before we end up with a complete MDS on our hands? We want to know what our score is, right? So that's the purpose of the tool we looked at a minute ago. But as you can see here, if you code someone as independent or setup assistance, which would be a 5 or a 6, the score is a 4. So a 4 is independent, is the most independent person, and then 0 is the most dependent person, or a person that refused, or the question was not applicable to them, or it was not attempted, is a 0. Independent is a 4, 0 is dependent, or it was not assessed for whatever reason. So I want to make sure we're really clear on that. The higher the score, the more independent, which is completely opposite of G. Again, just to be confusing. Okay, let's go to the next one and we will see a little bit more about this whole scoring. So under GG, again, these are the PDPM items. And when you score it, your score is a 0 to a 4, right? You were either dependent or not assessed, or up 1, 2, 3, or 4 being independent. As you can see here, there's 6 different buckets. Some look very familiar. They're eating, oral hygiene, toileting hygiene, basically your bed mobility, which is sit to lie and lie to sit on the bed. And then your transfers, which include your sit to stand, your chair to bed, and your toilet transfers. And then you've got your walking, right? So there are asterisks next to the oral hygiene and the walking. And the reason for the asterisks is that those are the 2 items not included in the nursing score, right? So all of these items get coded on the MDS and then scored, and you will have a different score for PT and OT, and I mean, for PT and OT it's the same, but for nursing it's different. All right, so let's look at something else here. Let's go, well, let me just say back to that. If you have in 6 different buckets, if you are completely independent or set up, there's 6 times 4, independent for PT and OT would be 24. It's independent score for PT and OT. For nursing, there are these 2 items that are not included. So that means there's only 4 items times 4, it'd be 16. So let's look at the next slide and we'll just keep that in our mind. That as we look at the breakdown in the PDPM methodology, for PT and OT, they broke down the different PT-OT categories by, as you know, the primary reason for the SNF stay and the GG score. The GG scores are broken down in these ranges, 0 to 5, 6 to 9, 10 to 23, and 24, which is independent. And as we saw a minute ago, historically, this has been taken from PT and OT's eval, and 10 to 23 is what we saw. And that is the highest reimbursed typically, except for the joint replacement, that is the highest reimbursed for PT and OT because that's what we were telling CMS on the patients that got the most therapy, that's about how much they, that's about, they were able to participate in therapy a little bit more. That's some of the logic behind it. So you're going to get paid a little bit more for therapy if they're able to participate. If they're independent, you're not going to get paid very much because they don't need that much therapy, right? That's the PT-OT side of the scoring and how it impacts your PDPM reimbursement. From a nursing perspective, it makes sense. You're going to be broken down in 0 to 5, 6 to 14, and then your independent is more 15 to 16. It makes sense that you're going to, on your nursing side, get paid more for the more help your nursing staff is having to provide to care for the patients in those items of bed mobility, eating, toileting, transfers, right? That's your staff, that's your labor cost. So you're going to get paid more in nursing for the more dependent they are, and you're going to get paid more in therapy the more they're able to participate in therapy, a little bit more independent. It's completely opposite. Nursing is weighted very heavily, as you may know, on the PDPM model of reimbursement. So for every reason, we want to get real GG baseline data from what's really happening with that patient from the minute they come into your door through 11:59 p.m. on that 3rd day of the stay. Not just from that one eval that PT does to check out their toilet transfer, right? And how many times do we watch the patient eating in therapy? How many times do we watch them brush their teeth in therapy? That's not usual. The whole point here is to capture how much help that patient needed upon admission for the baseline. So let's go on to the next slide and talk a little bit more about this. Core is a company that has a product that analyzes the claims versus basically the HIPS codes. So what did we capture on that MDS that's being reported to CMS, right? So it's looking, this is coming from the claim. So from the initial baseline assessment, what are the GG scores that we saw back in October versus what we're seeing now in the first quarter of 2020? So for nursing, I find it very true what we're seeing in our setting as well. And I will tell you that CORE has over 1,200 clients, I believe, submitting their claim data. And that's probably conservative at this point. So when we look at the nursing function score, remember the more dependent is the 0 to 5. That's where the highest dollars of reimbursement are, because that's where your heaviest in cost of your staff is invested in caring for these patients. So back in October, we saw quite a bit. I'll start at the top and see for independent, for 15 to 16, we had about 6.2% of the claims were falling into that range, versus the first quarter of 2020, we're looking at about 2.2%. And then if you move on down, you're showing people moving from 6 to 14, down even further, 69. And then you look at the dependent was at 21.6% and is now at 28.2%. That's what we're seeing now. And I'm hoping that that's a reflection of a truer gathering of baseline data, truly what's happening at the bedside for these patients on their first 3 days in your locations. So that's the nursing. Again, that's the bed mobility, the eating, the toileting, hygiene, and the transferring, right? That's what that's showing. And then we come to the PTOT score, and 10 to 23, you can see that's where the majority of the patients were falling. That's what therapy was reporting for, for many, many days. Because when you think about it, when somebody comes into the therapy department or is in the midst of a therapy eval, I'm a physical therapist, and I will tell you, I set that patient up for optimal independence and success. I want to help them be as independent as possible. I'm prompting, I'm cueing, I'm setting the room up, I'm teaching them how to be as independent with their skills as possible. After I'm done with them and they go back to their room, they're exhausted, they're tired, they don't have any energy to get in and out of bed and move themselves in bed. And it's a totally different picture. You're not going to get usual performance from an evaluation completed by a PT or an OT, in my opinion. So if part of the picture, yes. Part of the discussion and interdisciplinary team, absolutely. But we want to focus on capturing what's happening at the bedside with this patient, usually in those first 3 days. So you can see what happened here. In October, there was about 2.3% independent at 24. That's gone down. And if you look at what has gone up, the more dependent ranges have increased. So look at that 6 to 9 range has gone from 16.6 to 21.4. And the 0 to 5 range, the more dependent, has gone from 12.6 to 15.7. To me, I believe that's a true reflection of what's happening at the bedside. So it's a shift. I just wanted to point that out to you. I just want to encourage everyone to really, really focus on usual. So let's talk about that. How do we do that? So let's look next at what items we're talking about here again. So for PDPM, the GG items are in green that impact your reimbursement. We've been talking about these items. The rest of the items in black are still being used by CMS to look at our performance and our outcomes, right? So we're looking at showering and bathing and upper and lower body dressing and putting on and taking off your shoes and rolling. How was that person when they came into us, and how much improvement did we make on discharge? So discharge and baseline GG all matters. It matters for your reimbursement, and it matters for telling the story on your outcome. So I hope that's a little bit clear. So if we go to the next one, we're going to talk about how do we gather this information, right? How in the world are we going to gather all this? So who's involved? It's got to be based on what that patient is doing all throughout those 20, from the minute they get there, 24/7 until you get to that 11:59 on the third day. So it's the resident themselves, nurses, CNAs, therapy. The family can provide prior level of information on GG. That's very helpful. MDS, admissions might have information. So get everybody involved. That's the purpose of the interdisciplinary team. So we have to talk about the prior level of function, because that matters to the meaning behind our discharge and our improvement on our outcomes. Usual performance, I've said it a million times, first 3 days of the Part A stay, admission to 11:59 p.m., day 3 of the stay. We want to make sure that the goals are based on consideration of what the patient was able to do before What are they able to do now? And where are they going? What are their discharge plans? And what do they have to be able to do to safely transition? Just pick those goals that matter, that have got to be accomplished, and make sure everybody knows them and everybody's working on them, from the CNA to the therapist to everybody in the building. And that's my dream, of course, it's a dream, but I can hope. And then what we have to do at discharge is make sure that we are capturing usual performance in the last day of the stay and the 2 days prior. And honestly, I never hear discussion about that. It just hasn't been as important as it is when we're being judged on our outcomes, and our outcomes are coming in large part from GG. So where is all this captured, right? So the documentation on the level of assistance, the MDS coordinator is one person. She's got to be able to have the documentation to support what she's inputting into the MDS. We've got to have documentation to support this. It's going to fluctuate during different times of the day. Who was helping them? Where were they at when they tried the task? How tired are they? Are they groggy because of their medication? Are they in pain because they need more medication? All of those things will impact the functional level of the patient, and that makes sense. It's okay to have different levels documented. That makes more sense than seeing the same thing documented repeatedly every time of the day, every shift. There are many trackers available out there. ANAC has a tool, and they've graciously allowed us to utilize their tool and share it with you all. If you haven't seen it, most people have seen it in the industry. But I do want to say that the best practice to pull this together and support your GG under review is to have an IDT note entered into the medical record that states that the IDT together determined the usual performance to be XYZ. And that needs to be what is on your baseline level and at discharge. So if I'm an auditor coming in, I'm trying to figure out, how did you get this GG level that is paid higher than what you used to be paid, or it looks different, or does it make sense? Does it make sense? Was it an interdisciplinary collaborative decision? How did you get to it? Those are the questions I'm assuming will be asked. So then as we go to the next slide, we're going to really talk about how do we do this? So direct observation, right? The resident self-report, report from all the caregivers, looking for the usual performance. And I pulled in that RAI information. What is their guidance on usual, which is the hardest thing, right? It's not their best and it is not their worst. It's their usual. So you cannot take a one-time eval or even 1 or 2 times of looking at somebody's bed mobility when they move with the staff throughout the day, multiple times during the day, right? So it's got to be, the other confusing thing about this is that it should be conducted. Your baseline assessment should include that patient's performance prior to the resident benefiting from interventions in order to reflect the true admission baseline functional status. I want to let that sink in. Really, truly, it needs to be conducted prior to the resident benefiting. Once they start benefiting from the interventions, you no longer put that into the equation as, is that part of how they usually performed or not? And it's got to be item specific. They might be getting therapy for bed mobility, and they started making improvement in bed mobility, but maybe they're not getting intervention for some of the other items. You've got to talk amongst yourselves. Okay, let's keep going. And it's got to be a helper is the question. How much help did the patient need from the helper is the word used. That has to be an employee. Here's the ANAC tool. It talks you through all of the self-care and mobility items in GG. It gives you a place to document AM, PM, and it gives you a place to initial and signatures. And it gives you the actual scoring definition and the definition of each of the GG item sets that have to be coded. If you get into the REI manual, it's going to be even more specific. And I'm going to talk a little bit more of that in just a second. So then if we go to the next slide, we're going to see a decision tree that is on the flip side of the form, and it will help talk you through it, right? So the question is, does the resident need physical, verbal, nonverbal cueing, setup, cleanup, or complete the self-care activity? Yes, keep going. No, that's your code. That's what you're going to do all the way through. And you can see as you get down here, the trickiest part is probably, does the resident need lifting assistance or trunk support with the helper providing less than half the effort? Yes or no? If it's yes, partial mod. No, it's more than half the effort. Then it's substantial max. To me, that is the grayest of the gray here, because you have to break down that task into all these different steps. But anyway, there is your coding definition again. And then the next slide, I'm going to show you what I think is a very helpful gift from CMS, which are the training videos. These will take you to training videos that have a CNA with the patient performing a task that has to be coded for the MDS. It asks the question, and they just recently updated these, putting on and taking off footwear, walking 10 feet, and picking up an object. I highly, highly encourage you to go to those tutorial videos. And when you open the link, here's what you'll see. The next slide is an example. So if you click walking, you'll see a video with a CNA walking a patient, and then it will, when you go to this, open it up, you always want to note that you select the skilled nursing facility, because your questions will mirror your GG MDS item set questions. It's a little bit different language in home health, as you can imagine. Just a little tip. So if when you get this handout in PowerPoint, you will be able to watch the video by clicking on some of the links we provided. So I highly recommend that for training purposes. I can't stress it enough. Okay, let's go to the next one. This is an example of a decision tree for eating. It's just trying to help, like if you wanted to use it as, kind of a cueing for your staff. Did the resident need any assistance? Physical, verbal, nonverbal cueing, bringing food and a liquid to the mouth and swallowing. That is the question we have to answer. How much help did they need to bring food or food or liquid to the mouth? And then answer, if it's no, you code independent. Yes, continue. So I'm not going to go through all of that for the sake of time, but I'll let you go through that. So if we can skip to the next slide. And then the next one after that, because again, it's talking you through that partial, moderate, substantial max. Where are we with that? And really that substantial max level of assistant with one helper providing more than half of the effort on, that's the same language. One helper providing more than half the effort of any task is substantial max assist. So if you think about somebody standing and transferring, that is you have to scoot to the edge of the chair. You have to lean forward. You have to stand up. You have to pivot. There's a lot involved. If you're just helping that person with lean forward so that they can scoot to the edge of the chair, is that more than half the effort of that transfer? It gets really confusing really fast, which is why I love the videos. And don't be afraid to code the not attempted items at the bottom of the slide. If the resident refused or was not applicable or not attempted due to environmental limitations, those are really important to utilize to tell the real picture. Okay, let's go to the next slide. And I want to just end my section on the GG myths, right? So myth number one, do you wait for therapy eval to start collecting the GG item? No, do not wait for therapy eval to start collecting GG data. GG data collection starts the minute they come into your building, and it is on 24/7. You're assessing that patient's amount of help needed until 11:59 on day 3 of the stay. So this is definitely a gray area. And I think I've hit upon the fact that it's usual is rarely seen by the therapist. Okay, I think I've hit on that. And then myth number two, all GG goals must be selected to avoid dashing. I really want to make sure this is clear. CMS has responded that SNFs only have to code one of the section GG discharge goals, as long as at least one goal is coded. Up to 11 section GG discharge goal may be dashed without impacting the QRP data, which again, we can't have dashes in the baseline. That means it was not assessed. They want you to assess the patient. That is the main push. Select the appropriate goal because you will be graded on our improvement on our goals. Just make sure we don't set every goal as independent, which we see all the time and is totally unrealistic. Do not set yourself up don't set yourself up for that. Myth number three, avoid using not assessed coding options. No, That is a myth. This is a great enhancement over G. Under GG, we're able to utilize all of these options to explain why something was not assessed. There is not a penalty for using these not assessed items. This is what we need to do. You should never have a dash on a baseline because you can always find a reason under the opportunities they have presented to us that it was not applicable, or maybe it was due to environmental, or maybe it was a medical complication that you wanted to avoid. Okay, so don't be afraid to use the not assessed reasons provided to us by CMS. Just do not have dashes on the baseline. You are able to use dashes in the goals, and you should dash out anything that is not going to be worked on, and your goals can be actually less than the baseline if the patient is not here and able to improve and you say they're on hospice or something. So with that, I'm going to turn it over to Ken for the next poll, and then to my colleague Megan, who's going to go into more of the QRP information. Thank you, Ken.
Okay, thanks so much, Susan. We're going to bring up our other interactive poll real quick. You'll see a question on your screen right now. How many of your skilled patients discharge having met their GG goals? So if you could take a moment, vote live. We'll give this a few seconds or up to a minute or so to allow everyone to vote, and then we'll share those results. But that should be pretty illuminating based on everything Susan was just covering. And then we'll share those results, and then we'll jump into Megan's section here in just a second. So we'll leave this open for maybe 5-10 more seconds. Okay. Great. I'm going to go ahead and end that. Thank you for voting. Let me share that real quick. And then Susan and Megan, you guys can take a look at this. I'm guessing probably kind of what you expect. Megan, I will let you go ahead and get started.
Go, Megan, go.
Good afternoon, everyone. As Susan touched on briefly, gone are the days when we only worried about the completeness of the MDS in regards to the SNF Quality Reporting Program, or SNF QRP. I'm going to spend a few minutes talking about Section GG's role in our quality measures and why accuracy is vital for the facility. So not only does Section GG need to be collaborative and accurate for payment purposes, but also for our quality outcomes. CMS is not in our facilities every day, or at least I really hope they're not. So we need to paint the picture for them. Who are these residents that we're caring for, and what level of assistance are we providing them? What do they need to be able to do before returning back to their prior living arrangements? We know we're doing the work, so let's show what we're accomplishing through our outcomes by really focusing in on true baseline status and appropriate goals. We're first going to look at each of the functional outcome measures included in the QRP, beginning with the discharge self-care score. This measure estimates the percentage of Medicare Part A stays that meet or exceed an expected discharge self-care score. So who triggers? The numerator includes the total number of Medicare Part A SNF stays with a discharge self-care score that is equal to or higher than the calculated expected discharge self-care score. And then that denominator is the total number of Medicare Part A stays except those that meet the exclusion criteria, and we'll get to those exclusions in just a minute. Next, we have the discharge mobility score. This measure estimates the percentage of Medicare Part A SNF stays that meet or exceed an expected discharge mobility score. That numerator includes the total number of the Part A stays with the discharge mobility score that's equal to or higher than the calculated expected discharge mobility score. And then we can go to the next slide. We're going to get into the change in self-care mobility scores. So the next measure is the change in self-care score, which tells us an estimate of the risk-adjusted change in the self-care score between admission and discharge among Medicare Part A stays. And then we have the change in mobility score, which tells us an estimate of the risk-adjusted change in mobility between admission and discharge. So those are the 4 areas that use our Section GG data. There's 2 for self-care and 2 for mobility. The 2 change in score outcomes are where we can really show our success stories. They paint the picture of the resident's functional ability when they admitted versus when they discharged. We can go to the next one. We'll talk about these exclusions. So these are the residents that are removed from the calculations because the outcomes are not under your facility's control or they're unavoidable. So for instance, Medicare Part A stays that are incomplete, your unplanned discharges to the hospital, including psych hospitals, long-term care hospitals, and also discharges against medical advice. Residents with a Part A length of stay less than 3 days, and residents who expire during the SNF Part A stay. Those are also excluded. The resident may also be excluded if they're in a coma or vegetative state, are younger than 21 years of age, are discharged to hospice or received hospice while a resident, or if they had no PT or OT services at the time of admission and recorded on the 5-day PPS assessment. So that's no minutes recorded on the 5-day for PT or OT. And then next, we're gonna look at these risk adjustments. So the covariates. These are the items on the MDS that are used to risk adjust the 2 discharge score measures and the 2 change in score measures. It's very important for the MDS to be coded accurately in order to capture these covariates and for the measures to be risk adjusted appropriately. So these are some of those green hexagon symbols in the Briggs color-coded MDS that Susan referenced earlier in the presentation. So you can kind of see, it'll tell you whether or not those are risk adjustments for those items or not. And we can move on to the next one. So how are we going to monitor all of these outcomes? It makes sense to monitor the resident's progress towards goals based on section GG. The rehab goals and plan of care should mirror the functional goals established by the IDT in section GG. And if you're not already, start care planning your GG goals. You may be thinking, the section G isn't gone yet. And I know we're all used to using that verbiage in our care plans, but section GG is already here and soon to be the only measure of functional status. So we need to be care planning in that same language that section GG provides for us. We know that CMS is focused on outcomes, and these functional abilities and goals are huge. If CMS is dialing in, we should be as well. It's a good idea to use progress towards those section GG goals as a way to identify transition readiness. And this is where the accuracy of those functional abilities and goals that we set upon admission really matter. By collecting that prior level of function and establishing attainable goals, we're truly able to identify discharge readiness regardless of the setting. If we're setting unattainable goals to begin with, like coding everybody independent, even though we know we're probably not going to get them to independent, we find ourselves working towards something that isn't realistic, the outcomes suffer, and it's a total domino effect. So it's important to monitor the progress towards these goals, in my opinion, at least weekly, if not daily. It doesn't have to be formal, but it is a good idea to collaborate and document where the patient is at functionally according to the team. It has to be a collaborative effort. Also, if your resident is meeting skilled criteria through therapy, this weekly documentation really helps to support that continuation on skilled services. Many facilities have a Medicare meeting each week anyways to go over all their skilled patients. That's a great time to review the patient's progress towards the goals, their discharge readiness and functional accomplishments, as well as any barriers there might be to discharge. Sending a resident home before they've met their goals is not only potentially unsafe, but could have negative financial and quality impacts for the facility through the SNF claims-based measures. And we can move on to where do we monitor all of this data? There's a handful of reports available through Casper that serve as great tools in measuring and monitoring resident outcomes. The first one we're going to look at is the SNF QRP Review and Correct report. This report contains facility and resident level performance data for 4 full quarters. It'll show you each QRP measure, who triggered in your numerator and who was excluded, as well as functional scores related to the change in self-care and mobility measures. It will also indicate whether the data correction period is still open, which helps you determine whether or not you can still modify the MDS if you do identify an error during your review. And then moving on to the SNF QRP facility level QM report. This one shows an overall picture of how the facility is performing in each measure. It shows the observed as well as the risk adjusted scores. And it's a quick way to just identify opportunities for improvement and a quick way to see how you compare against the national average. And then next is an example of the SNF QRP resident level QM report. This is where you're really able to drill down into the nitty-gritty and see which residents are triggering which measures and whether or not the outcome was desirable. You're also able to view the observed change in the self-care and the mobility scores. And then finally, the SNF QRP provider threshold report. This report will show you whether or not the facility is meeting that 80% minimum MDS completion requirement for the annual payment update determination. When we talk about the threshold, it's important to note that it's 80% of the MDS assessments and not 80% of the MDS items. That does make a difference. These reports are a few ways to monitor your outcomes and keep an eye on how your facility is performing in the eyes of CMS and the public. It really is a collaborative team effort. So to get these reports, if your facility uses Simple LTC, you can pull your CASPER reports there. If not, you can log into Keys and run those there. And I'm going to now turn it over to Corey Polly with Simple LTC.
Thanks, Megan. What we wanted to show you a couple guys, some recent additions to Simple LTC that we deployed. If you're a current customer, you may find this very useful. If not, and you'd like to hear more about this, please reach out to us and we'll give you an opportunity at the end of this webinar. But we did recently deploy more QM tools specifically for some QRM measures. Some that we were talking about here, the discharge or the mobility and self-care scores and a couple other QRP measures. These tools add some extra functionality beyond what the CASPER reports provide you. So you can do a little bit more digging into who's in the numerator and why in the numerator and denominator and why they are in the numerator and denominator, what on the MDS actually put them there. So please, if you haven't seen it yet, check it out, see if it's helpful to you and give us any feedback you can to make it more useful. Next slide, please. Next, I want to show you some population, some semi-national population level statistics around the GG scoring that's happened in Q4 of 2019. So the way we do these calculations, the same way the calculations are done on the QRP measures, is we sum the score of the self-care GG items and the mobility GG items. For self-care, the score can be from 7 to 42. At entry and at discharge. So when you see an increase from the entry to a discharge, that would indicate an improvement in function. And then on the next slides, we have about 6 different slides where we're showing a few different ways to look at the population overall. So if you're looking at the entire population here, this is about 60,000 Medicare stays that we have in our data from October to December in 2019. You'll see self-care scores generally don't improve. That might as well be equal. Those numbers are so close. The margin of error in this measurement would basically say this is an unknown, how much has changed. Whereas the mobility scores have obviously improved, and that might make sense, right? That's generally where therapy might focus. But this is just to give an idea of what CMS is seeing for the end of 2019, so Q4 2019. And this will impact the expectations they will have in 2022. On the next slide, we've broken it out by a kind of a subset of that patient population. So urban versus rural for self-care here. Again, you'll see there's not a whole lot of change. And on the next one, we show it for mobility measures. Similar to the global difference, you can see slight difference in the baseline for urban versus rural. Not really sure where that comes from, but I'd be curious to dig into that more. And then on the next one, on the next slides, we break it out by a couple of the covariates used to do the expected calculations. So as Megan mentioned in there are some covariates that go into predicting an expected discharge value for a resident based on a number of things. These are a couple of the important ones. Here in self-care, you'll actually see it. And most of the time, not a change, but there is an obvious increase for orthopedic primary diagnosis patients or residents, where there's obviously been some focus for therapy to improve self-care here, and CMS sees this. And on the next slide, we'll show you the mobility numbers. And again, it makes a little bit more sense for patients coming in with an orthopedic primary diagnosis to maybe get a little bit more attention from therapy. And I believe that is our last slide. Do we have one more? That is it. I will turn it back over to Susan.
Oh, thank you. So this is just an overview of quality rehab management. We do appreciate your time today and hope this has been of value, and I look forward to some of the question and answers. This is just a quick overview of what all we provide as a in-house rehab management organization. And then I'll turn it back to Ken to talk about Simple LTC perhaps.
Okay, yeah, just a very brief note about Simple Analyzer, because Corey just went through the data for a few minutes there, so you can see some of the possibilities as we dig a little bit deeper into the Section GG details. But as a quick overview, Simple Analyzer is our main analytics and MDS scrubbing tool. It covers a lot of categories as we continue to add functionality to it extensively over the past few months and years, especially even more recently with the COVID crisis that we're all facing. So there are some new analytics for COVID-19, segregation and delineation in there. Section GG specifically, you saw some of the highlights there, as well as how all of that impacts PDPM as a whole. Some very easy to use PDPM tools in there. An MDS 5-star predictor tool, which uses real-time data, predictive data to manage your, or predict out multiple quarters, your 5-star, as well as your QMs and how those are not only looking today, but how they will look 2 to 3 quarters from now. And all of that data is done, scrubbing is done pre-transmission as well. So before we move into our Q&A session, we've got a number of questions pending, I see, and we still have we've got a lot of people asking questions and standing by. So one quick poll before we jump into Q&A. This is just to give you a chance to let us know if you want any follow-up. So just 2 quick questions if you would answer briefly. Would you like to learn more about QRM and their services, or would you like to schedule a personalized demo of Simple Analyzer, or both? Just let us know quickly. We'll leave that up just for a minute or so as we jump into Q&A. And as I mentioned earlier, Melina has been standing by, and I think also Amy with QRM has been monitoring the questions. So Melina, I'm sure you've filtered out some of those to start with. What's our first question?
Our first question is from Janie. Janie asked, when assessing the GGs on the eval, if the patient is unable to perform a task, how do you recommend them to score?
You would definitely utilize one of those options that CMS has given us. You would either, if it's not assessed, you would either say that it was because it was not applicable. Let's say the person didn't do that before their onset, or perhaps it was not assessed due to medical risk, complications, or the patient refused. I mean, use one of the codes that's available to us, and that's fine. That's not a penalty. It just presents a truer picture.
Okay, great, thanks. Brandy asked, if therapy does a GG eval and nursing does a GG eval, which one is used to code the MDS?
You're going to gather information from all of the team members, especially the CNAs, and we're not going to use just a one-time snapshot eval or 2. We're going to look at truly capturing what's happening bedside with that patient. How much help does that patient need in those tasks? From the admission minute they get there till 11:59 p.m. on that 3rd day. Cannot stress that enough. Do not just take an evaluation one-time snapshot or 2.
Okay, great, thanks. Marcella asked, what about GG goals for residents that are long-term care and we skill for nursing only? Is it okay to code discharge goals GG the same as admission performance if that's their baseline?
CMS has said you can choose a goal that, make it applicable to that individual person. We want it to be individualized. There are going to be people that are skilled that are declining, expected to decline, and that's okay. We need one goal at least to be care plan. Select at least one goal and then care plan that goal. And the goal might be set at a lower level than what they're at on admission baseline even. So make it make sense and individualize it to that person. Prior level critical.
Okay, perfect. Perfect, thanks. Lainey asked, what is the proper procedure for coding discharge GG when the patient discharged to acute care hospital? When this happens, the PT typically has a decline in function 24 to 48 hours prior to the discharge. Do we code off their performance before the rapid decline or the performance with the decline?
You want to capture what happens on that last day of the stay and the 2 days prior. again, taking it from the interdisciplinary input of how much help is the patient needing truly at bedside, throughout all of the course of their day. Usual performance, we still have to go back to that. I'm sorry, I just keep saying it over and over again. Don't just take the discharge summary from the therapist. Talk about it. It's important that the therapist can interject what they're seeing as part of the team, but the interdisciplinary team has to decide based on everyone's input on what truly happened with that patient in those last days of the stay as guided by the REI manual.
Great, thanks. Manaz asked, if the resident doesn't walk without therapy help and just walks at a therapy session, how are we supposed to code it?
Why weren't they walked? I mean, I think that's the question. If they're not walking, why weren't they walking? Was it because there was a risk of was a medical concern? That's a very difficult question, and one I think that is addressed in the REI manual more clearly. And I do want to go back and just clarify, if someone discharges it's an unplanned discharge and it's coded that way on the MDS, then your discharge GG is not like an MDS item. Probably that question was more from a therapist perspective. So, I think that the therapist documentation should tell the story. How much progress was the patient making? And then you can see the patient had a decline and a change in function, and then they discharged to the acute care. Just make sure the documentation tells the story. Thank you.
Yeah, it depends on whether that discharge was planned for a surgery or something like that versus unplanned. They were sent out, for something critical.
Okay, great, thanks. Samantha asked, if therapy evaluates on day 2, does nursing still use day 3 of section GG documentation to code usual performance, or does usual performance end once therapy has initiated intervention?
So that is a very good question, and it hangs up a lot of people. That's what we were talking about a little bit earlier. Once the patient starts benefiting from intervention, usual performance is taken prior to that for that task. So if therapy started really working on bed mobility transfers or walking or something like that, before they started showing the benefit of intervention, take what they performed and calculate usual. Don't include the performance of when they were, now they've benefited from intervention. It's so hard. That's a hard question.
Okay, great, thanks. Lainey asked, in relation to the idea that section GG goals should be set with the IDT, assuming the PT eval is completed, might be a repeat, on day 2 and the IDT meeting does not happen until day 3, do you have to go back and adjust the goals in the PT eval to meet the IDT GG goals? It seems it would be important that the goals in the therapy eval match the goals in section GG.
That is such a common situation that we're finding, is that therapy does their eval and answers the question on their eval as to what they're seeing in GG. That's all they can do, right? So their eval is their snapshot in time. That's what they're doing. So when you have a discussion on maybe day 4 to say, okay, last 3 days of this day, what are we going to decide is usual performance? Therapy is going to say, this is what I saw in my eval. Nursing can contribute what they have gathered from all of the documentation and the communication and the assessment made based on what they are gathering from frontline caregivers and everybody else. And then a decision has to be made as to what was usual before the intervention. I know I probably went off on a tangent, but I hope that helps somewhat.
Great, thanks. And our last question is from Samantha. Samantha asked, how do you suggest the team identify an appropriate discharge goal score? If we set a low goal, then we will meet or exceed it and will look great on outcomes, but I feel like this is cheating the system. What advice do you have to identify the appropriate goal? PLOF is not always realistic.
I think we need to really have discharge planning beginning on day 1. That's what we've always talked about. We've preached it. We've learned it. We know it's so important. If we know where that patient is going, if they're going back to long-term care, then, walking 150 feet in a corridor is not as important if they are going as if they were going to an assisted living and they had to walk 200 feet to get to their meals. You have to make it individualized and specific to what it is that that person has to achieve for a safe transition to the next level of care. It has to be individualized and specific to where that patient needs.
Okay, well, thanks so much, Susan. We apologize if we did not get to everyone's question. I know we had several out there, and there just wasn't enough time to cover all of them in the time that we have allotted today. What we will try to do is follow up with QRM and see if we can publish an FAQ, including all those questions and answers, and then we'll get that out to everyone as soon as possible. Want to remind everyone, oh, Susan, you've got some references on here. Do you want to point anything out about these? Oh, no, just feel free to, I think that definitely as Ray asked all these questions, it's best to go back to the source document, which is the MDS and the REI manual. And then all of the CMS guidance on the SNF quality reporting measures, all of those, I definitely encourage you to go back to the source. Okay, thanks so much. And just a reminder, as I mentioned earlier, today's session was recorded, and you can get that recording as well as the slides at this URL on the Simple LTC website. Super simple, simpleLTC.com/GG. Give us an hour or so to get that recording up there, but that will be available there along with the slides, handouts that have all the references that Susan mentioned on there as well. So we want to greatly thank our partners and friends at QRM. We love working with them. You guys did a great job with Susan Kroll and Megan Usry pulling together all this content. We know it was a lot, but you guys covered some very important detail at a kind of critical time. And I also want to thank Corey Polly with Simple LTC for chiming in with some important data that digs a little bit beneath the surface to show what we're actually seeing under there. So again, thanks to everyone for attending today. We know this is a difficult time, especially to find time in your schedule, as well as to figure out what to prioritize on. We hope you found today's content helpful. We very much thank you for attending, and we hope that everyone stays safe. Please have a great day.